All right, it's my pleasure to share a presentation regarding pediatric oncologic emergencies for you. I want you to sit back and fasten your seatbelts, and let's just jump right into this. So here's a case to consider: a 7-year-old normally healthy boy who presents with 2 weeks of easy bruising and then nosebleeds and gum bleeds. Comes to the ED, has a temperature of 36.9, is a bit tachycardic, respiratory rates normal, blood pressures are okay. He's alert, has dried blood clots in the nares and the gums, and a small scab on his ear, as well as petechiae on the lower extremities here. I would like you to already be thinking about a differential diagnosis in this case, but you do order some labs, and they show up as following: white count of 9.2, hemoglobin 9.1, differential is not yet reported, and platelets of 5,000 here. Perhaps what comes next is some coags, ProTime 12.5, PTT 24, and fibrinogen on the lower end of normal 164. Elevated D-dimers are seen in this case. And then in trickles, the differential, they are severely neutropenic. There's plenty of lymphocytes around, and they're reporting out promyelocytes here. What are promyelocytes? So you don't have to remember much about promyelocytes, except that they're an early form of myeloids, and you normally don't see them on your differential here. In fact, if you look at the smear here, you see these large blue cells here, full of vacuoles. And these are indeed promyelocytes that are shown here. This may very well be a presentation then of something called an acute promyelocytic leukemia. Shortly after presentation, the patient complains of a severe headache, vomits a couple of times. You obtain a CT scan, and it shows intracranial bleed here. So I am trying to share with you a case of presentation of acute promyelocytic leukemia. They typically present with bleeding, heavy menses, petechiae. Their white count's typically is not high, as you might expect for other leukemias. Hemoglobin can be high, low, or whatever, and platelets may be normal or low. And this is a condition where the leukemia has resulted in an arrest in myeloid differentiation at approximately the promyelocyte side here. There are typical retinoic acid receptor gene rearrangements and chromosomal rearrangements that are seen. I'm sharing this with you because this is a case of an oncologic emergency. Approximately 15% of adults with this leukemia present dead. So it's one that you want to recognize quickly and initiate the intervention. I think in the pediatric population, we're a bit better than in the adult world, perhaps. So the management here is really, you need to correct the coagulopathy. So if there's thrombocytopenia, they need platelet transfusions. If the fibrinogen is low, you administer cryoprecipitate. If you have prolonged ProTime or showing up as perhaps that should be INR greater than 1.5, then you can administer vitamin K or FFP. The treatment for APML now involves what we call differentiating therapy, and one of the differentiating agents is all trans-retinoic acid. And ideally here, you can provide the initial step towards cure, as well as getting them out of a potentially life-threatening situation by administering ATRA. We like it when our patients present to the emergency department and receive their first dose of ATRA in the emergency department. So that's a case of bleeding in DIC. It doesn't just occur in acute promyelocytic leukemia. It can occur with other leukemias as well. Some other AML forms tend to do this. Occasionally you'll see it in a solid tumor, sometimes in hepatoblastoma, where there's a lot of consumption going on from an intrahepatic hemorrhage. The principles remain the same: correct the coagulopathy, correct the thrombocytopenia. Those cases, of course, would not be not be responsive to ATRA. All right, let's move on to another case here. This is a case where a 12-year-old girl presents with fatigue, new onset headaches. She's not thinking quite right, has some slurred speech. On exam has a left facial droop and is obviously tachypnic. Has fever, tachycardia, and tachypnea. Appears ill, lethargic, in moderate distress. Whopping flow murmur that you can hear across the room. On exam, also cervical lymphadenopathy and that facial weakness that I mentioned here. Laboratory data starts to trickle in. You see a white count of 248,000. That's high. Hemoglobin 5.6, that's low. And platelets 45,000, that's low also. If you had the opportunity to look at the smear, it might look like this. This is a lot of ugly, large leukemia cells here. This patient had tachypnea and tachycardia, so you obtained a chest x-ray appropriately. It's shown here with a sort of diffuse alveolar infiltrate appearance. Because of the altered mental status, a CT scan was obtained, and again showing an intracranial hemorrhage here. So what's going on in this case? Obviously, we have a case of leukemia with that high white count and the cytopenias, but this patient is not presenting with just mild fevers or extremity pain as a very common presentation of acute lymphoblastic leukemia. This patient's presenting with altered mental status and tachypnea. This is a case of hyperleukocytosis syndrome. So what happens when you have too many white cells floating around, particularly if they're large and sticky, like some AMLs tend to be? You have complications of leukostasis, basically. So there may be neurologic complications or altered metastasis, as we present in this case here. There might be respiratory presentations. The patient may be hypoxic. They may be in tumor lysis syndrome or have acute renal injury. They may be presenting with bleeding, infection, coagulopathy. And about 3% of patients in the pediatric age range with hyperleukocytosis have early death. So obviously this is a oncologic emergency that requires prompt initial management. That initial management is largely supportive. So respiratory support, they need supplemental oxygen. That may require assistance with ventilation through BiPAP or mechanical ventilation. Hydration is important here. If you are intravascularly dehydrated and have high white count like that, you're contributing to the increased viscosity. You can correct that by providing hydration. We often will recommend at least a 2 times maintenance rate of IV fluids, such as just normal saline. You need to correct the coagulopathy if there is one. Remember that fresh frozen plasma or platelets for thrombocytopenia. And this may be a case where the most prompt intervention that's necessary is leukapheresis. And so working closely with your ICU colleagues for placement of a central line and leukapheresis may be in order here. You need to think about seizure prophylaxis. We will often initiate Keppra or some other anti-epileptic in this setting. So this patient had a hemoglobin of 5. What about correcting that one? I understand the temptation, hypoxic perhaps, anemic, you want to give red cells. Do you do it? This is one that I would urge you to consult with your hematologist or oncologist on. Because if you transfuse red cells, you increase the viscosity logarithmically here. So if you're already experiencing problems from leukostasis and hyperviscosity, by transfusing red cells, you may actually be making that problem much worse. So I'm not saying don't do it, I'm just saying do it in consultation with your oncologist. So the Initial treatments for hyperleukocytosis or hyperviscosity syndrome are hydration, I mentioned already, apheresis, and if possible, permissive anemia. Try to avoid that transfusion. And if you do need to do it, we often do it in a very slow correction, often as we're trying to reduce the white count through apheresis. In young or rather small children, instead of apheresis, it may be that exchange transfusion is necessary, and we often will do a two-body volume transfusion with cells that are reconstituted with either normal saline or occasional FFP in consultation with the blood bank. All right, another case. This time a 7-year-old girl presents with 2 weeks of cough. How often do you see that one? No fever, though. Is it a pneumonia? No fever might dissuade you from that. X-ray is shown here, and this is either a very bad infiltrate or a mediastinal mass. This can be shown better with a CT scan here, and here you have a large mediastinal, large thoracic mass here, and I think you can appreciate that it's encapsulating airway as well as venous and arterial structures here. So this is a case of superior mediastinal or Vena Cava syndrome. It's a rather dramatic presentation for some lymphoblastic lymphomas, T-cell leukemias, and other tumors that are shown here on this slide here. The symptoms basically arise from compression of these structures within a closed space. So tracheal compression or bronchial tree compression resulting in difficulty with ventilation or oxygenation, showing up as shortness of breath or even respiratory arrest. Compression of the vena cava or the venous structures results in engorgement of upstream structures. Think about plethora, swelling in the head, for example. This may be in part due to thrombus that occurs from the compression, and the symptoms that are associated in addition to the swelling and plethora might be shortness of breath or even syncope here. Okay. I'll ask you to, for a moment, to imagine the pathophysiology associated with the compression of these structures here. Obviously, if you're constructing the superior vena cava, not only are you causing a backup of blood flow to upstream structures such as the head, but you're also impairing the venous return to the heart. And so it may be signs of cardiac outlet obstruction as well. This particularly creates a problem if you try to sedate patients. So while recognizing this as an oncologic emergency, there's a few things you need to do very carefully, and I would say one of those involves sedation. If you use sedation, you then are potentially causing an exacerbation of the airway obstruction by relaxing the smooth muscles that help support that thoracic structure, keeping it open. Sedation may result in lower lung volumes, increasing the hypoxic and ventilatory complications. And plus, there may be a negative inotropic effect from the sedatives that you are using here. So decreased systemic and pulmonary blood flow, return to the heart, then can cause worsening problems with the cardiac output. So sedation is something that you need to use very carefully in a situation like this. There are ways to do sedation, but it needs to be done in consultation with anesthesia, ICU, and sometimes the ECMO team. So management for the superior vena cava syndrome here. One is thinking about the airway. You want to try and prevent respiratory distress. The patient may be best situated in an upright structure. I mentioned consultation with the ECMO team, and there may be a need for pleural centesis if the mediastinal mass is associated with a pleural effusion. For imaging, there's a couple things you can do to reduce the risk of compromise. Sometimes putting the patient in the prone position is much more comfortable for them and safer here. There's no reason you can't turn somebody upside down and put them in the scanner. Cardiovascular support requires fluid bolus. If there is a vena cava thrombosis, there may be a need for heparinization or catheter-directed thrombolytic agents. The diagnostic procedures here are important. You want to know what's driving this mediastinal mass here and therefore initiating some sort of therapy. The rule here, sorry, I'm having a lot of trouble with my slides. Okay. The rule here is to use the least invasive method possible to make the diagnosis with, therefore, the least amount of anesthesia. To affect tumor shrinkage in a short period of time, we often will rely on steroids or initiate chemotherapy promptly, and sometimes that's us taking our best guess of what the tumor may be. An alternative to chemotherapy and steroids might be radiation therapy. Okay, so in this particular case, sedation might involve using ketamine, which allows for more cardiovascular support. Pleurocentesis was used to eventually make the diagnosis of a T lymphoblastic lymphoma or leukemia. These are typically very sensitive to glucocorticoids, and so methylprednisolone was initiated. Okay, so you think you're out of the woods now by starting therapy on this patient to reduce the superior vena cava syndrome, but no, there's more to come. Early in the clinical course, you obtain some labs that are shown here. Serum creatinine is elevated for age, uric acid is up, and the lactate dehydrogenase, of course, is elevated as well. A couple hours later, you still have elevated serum creatinine. You've given some sort of uric acid lowering agent like rasburicase. All of this is an example of the tumor lysis syndrome and the things that you will see in this management. So in tumor lysis syndrome, this occurs when you have a high rate of cell turnover and therefore cell death. That can occur before therapy or immediately after it. It's associated with high tumor burden. That was a large mass in the chest. Tumors that are very sensitive to chemotherapy are particularly high risk for this. Burkitt lymphoma, T lymphoblastic lymphoma, or leukemia would certainly fit this bill. And it's a potentially life-threatening renal injury and electrolyte imbalance that you need to deal with in this oncologic emergency. So that means managing potassium, calcium, phosphate, and purine breakdown products, i.e. uric acid. The LDH is simply a marker of cell turnover. It's a signal. It's not something that you, of course, need to intervene upon. So I'll remind you of the pathophysiology in tumor lysis syndrome. On this slide here, you have a breakdown of DNA products. The murine catabolism results in elevated uric acid. Uric acid is not particularly soluble. It precipitates out in the kidneys, causing decreased renal function. You also have release of intracellular ions such as potassium, potentially calcium, and phosphate that are released. Those are all usually managed by your kidneys, but if you are now in renal injury from the elevated uric acid, your body's no longer able to manage that very well. Of course, if you have hyperkalemia, that may result in neuromuscular irritability and ultimately cardiac dysrhythmias and cardiac arrest. The management of tumor lysis syndrome involves hydration, allopurinol administration for those mild cases, but when we're really concerned about complications from tumor lysis syndrome, we like to rely upon uric oxidase or rasburicase. So in these interventions, there's a couple of other things to know about it. Uric oxidase or rasburicase acts directly at the level of uric acid, and so it's quite handy to relieve that agent which is not soluble, as I mentioned. Allopurinol inhibits xanthine oxidase, and therefore products sort of upstream from that can build up xanthine as well as hypoxanthine. Neither one of them are particularly soluble as well, and so while it may be reducing the uric acid and making that laboratory value look a little bit better, you have to be weary about its use, because you may be having a buildup of these other structures which are not soluble and therefore causing renal injury. Anyways, these are your two medical interventions for tumor lysis syndrome. So in management of hyperkalemia, you've probably been through this in other subspecialties and PICU rotations. Remember to do cardiac rhythm monitoring. If you have particularly high potassium, you may be administering calcium gluconate to stabilize the myocardium, to try and prevent life-threatening dysrhythmias. You can hide the potassium by using insulin dextrose combination. You can administer bicarbonate so that you get more albumin and protein binding of the potassium. You can administer potassium binding agents such as polystyrene sulfonate or K-oxalate. Ultimately, you may require help from your nephrologist with hemofiltration. For hyperphosphatemia, you can use phosphate binders. This really only helps out in the GI tract to try and reduce the amount of phosphate that's absorbed from there. It does not help acutely with the hyperphosphatemia that you see in the blood. So if this is a particular problem that requires prompt evaluation, you may need veno-venous hemofiltration. In management of hypocalcemia, well, you would think just give some calcium back, but that may not be the right way to go here. If you have problems with hyperphosphatemia and you give calcium, you're going to form calcium phosphate. Calcium phosphate, that's chalk. Chalk's not very soluble as well, and it precipitates in the kidneys. More kidney injury means more electrolyte abnormalities. So we like to allow permissive, therefore, hypocalcemia. And we only administer calcium IV for symptomatic hypocalcemia. What does that mean? That means muscle cramping or seizure, and just enough to get out of that particular emergency. If you require more intervention, again, you need help with your nephrologist with the hemofiltration. Okay, marching along on some of these oncologic emergencies. You've got your seatbelt fastened, I hope. Here's another one. Here's a 5-year-old boy who presents with 3 months of intermittent headaches, a bit more lethargic. He's had some vomiting. He's had an unstable gait. He's got a little bit of a head tilt here. He's lethargic appearing. Has bradycardia and hypertension. I hope you'll recognize this as part of Cushing's triad. Sure enough, on exam, he has a posterior fossa mass that is creating elevated intracranial pressure, and there may actually be some herniation that's occurring in this situation. So signs of the herniation, the hypertension, bradycardia, irregular respirations. So oftentimes you'll see a wide pulse pressure if you're paying particular attention to that, and then that head tilt is a common physical exam finding that you have. Presumably the patient is positioning them in a way to slightly reduce the symptoms from this increased elevated cranial pressure. Management requires airway protection. This may mean intubation, keeping the head elevated. Hyperventilation is sometimes used as a short-term management strategy. Mannitol as an osmotic diuresing agent, initiation of anti-inflammatory such as dexamethasone, or you may require surgical intervention with ventriculostomy. So here's another situation. Here's a 5-year-old girl who presents, who's known to have acute lymphoblastic leukemia. She's been going at this for over a year now and is in maintenance phase of therapy. She presents to the emergency department with fever. One of your first questions should be, is she severely neutropenic or is she likely to be severely neutropenic? And we define severe neutropenia as an absolute neutrophil count less than 500. This is probably a fairly common situation to you. You can make a huge amount of difference here by starting some prompt empiric antibiotic therapy. So I'll ask you then, what should that antibiotic strategy be? The incidence, or rather, fever neutropenia is a very common oncologic emergency. I'm afraid sometimes that you are so used to presenting to this presentation that you don't regard it an oncologic emergency, but it is. It's estimated that about 10% of fever neutropenia patients are septic, and therefore if you initiate prompt empiric antibiotic therapy, you can be administering potentially life-saving therapy. Even if it's not quite that dramatic, I hate it when something gets in the way of a perfectly good treatment plan, and sepsis and organ failure certainly can do that. And so even though this may not be an immediate life-threatening condition, it can affect the overall outcome of these patients. So again, what do you do for these patients? You initiate some empiric antibiotic therapy. Our goal is to administer something within 1 hour of the presentation to the emergency department or the clinic. And the rule here is to use a broad spectrum antibiotic that must include coverage for Pseudomonas. So that's your take-home message for a board question. Whatever it is that you choose has to have gram-negative coverage, in particular with Pseudomonas. There are a number of other oncologic emergencies that, for time, in fact, I'm kind of exhausted at the moment here, so I won't go through them, but they are other things to run through your mind at some point. And that might be spinal cord impingement or malignant hypertension. We do cause press sometimes in our patients, thrombosis of the renal artery, or even retroperitoneal hemorrhage or other massive hemorrhage condition. So please think about that and what you would do as a first intervention in those particular cases. So I thank you for your attention. Good luck on your board exams.